Welcome back. We'll get our final look at the urinary system and now take a look at secretion, excretion, and then the hormones. And so we've looked at the reabsorptive process. We've taken back essentially everything that we need to get back into the kidneys and into the bloodstream. And now we need to think about the things that we have to get rid of. And so the things that we're going to try and make sure that we're able to have present in the urine that is finally formed. And so any kind of substances that are potentially harmful, anything that is potentially from outside of our body that's water soluble that we can get rid of, those kinds of things are going to have to be gotten rid of. And so one of the things in terms of pH balance that we have in the body is the removal of excess amounts of hydrogen ions. And so we can raise up our pH and balance things out by either retaining those hydrogen ions or getting rid of them. We can get rid of excess amounts of potassium here, and so this can be taken away. Although this is important for our sodium potassium pumps, for our membrane potential in muscles and nerves, we do have the potential where we may need to get rid of some excess amounts there. And then we're going to do things like secrete our creatinine, our urea, our uric acid. All of those components are going to be gotten rid of as well if they haven't been done so in adequate amounts up to this point. And then we have all the other things that we, in a sense, kind of come in contact with. And so whether it be food products, and so things that are added, are preservatives, things like that that are in the foods. I mentioned before back at the beginning of the urinary system, we have all those things that you can't pronounce in your ingredient list that's on things that we consume. Other things that may be in the environment, things like pesticides. Those may be airborne or waterborne in terms of our exposure to them, or even through the skin. All of those kinds of things, air pollution potentially, all those kinds of things that are potentially harmful to the body, we're going to try and get rid of them through the urinary system here, and we're going to secrete them and push them out into the system, into the tubules themselves. One of the ways that we're going to help to kind of determine that we have, or what we have kind of going out in the urine itself, is in this juxtaglomerular complex or apparatus. Some places you'll see it as a complex, some places you'll see it as an apparatus. And this is important as we come in through the afferent arteriole. We have juxtaglomerular cells in there that are looking at the blood pressure as it's coming into the glomerulus itself. And then we've got this little triangle of cells in here, as well as along the distal convoluted tubule. And so within this distal convoluted tubule, essentially we have kind of a contact between the two. So that distal convoluted tubule always makes a return past the glomerulus one more time. These are going to do things in terms of the afferent arteriole. We'll talk about this in just a little bit as well when we start to talk about the hormonal aspects of the kidneys. And this is looking at things like the blood pressure as it's coming up. So is blood pressure too high? Is blood pressure too low as it's coming in? But the content of the fluid that's inside that distal convoluted tubule is also being monitored and looked at as well. And so that's what's going on in these particular cells here, is we're going to look at what's the content as far as sodium concentration, potassium concentration, what's the concentration of those substances just as they're about to come and get into the collecting duct itself. And so we're going to take one more kind of look at what the content there is. So what we have left by the time that we get to the distal convoluted tubule and the collecting duct there is essentially what we're going to get rid of. And so depending upon the content of what is there, in terms of the filtrate that we had in the beginning, we're typically going to have somewhere in the neighborhood of 125 milliliters per minute that gets filtered. But when it comes to actual urine production, of that 125 milliliters, we're only going to have about a milliliter left over. In other words, we're going to reabsorb almost all of the fluid in terms of the water that we actually pushed out in the first place. So the majority of all of that water is going to be reabsorbed, and we're going to take it back in But in that 1 little milliliter, we've got all kinds of solutes. And so we've had to have a fairly large amount of dissolved substances that are inside there. In terms of our normal kidney production, if we were really, really hydrated for some reason, or dehydrated, we would still need to produce roughly 500 milliliters of liquid a day in order to get rid of enough of the waste products that we have. In other words, in order to dissolve in, say, this is our little urine cup here that we're taking a sample out of, and that's our container there that we have. And as it's, in a sense, filled with urine, we're still going to need 500 milliliters in order to get all of the dissolved solutes to get inside there. And so of the solutes, we still need that 500 milliliters a day to get in there. And if you think about it, normally your urine output is going to be quite a bit larger than that. And so you're going to have quite a bit more, all depending upon how much water you're having throughout the day. So how much water are we getting in? So water in versus water out. And that's going to be kind of our inputs and outputs for any given day. Is at a minimum, there needs to be at least 500 milliliters being produced throughout the day in regards to what we're actually bringing into the body itself. Helping us control things within the body as far as our blood pressure is concerned, as far as our ions are concerned in the bloodstream, we have partially hormonal control over this process. So we talked about before about things like our sympathetic and parasympathetic controls in and around the kidneys themselves and how we can control those processes. But we also have hormones that can help out in this process as well. And so if we remember back to the brain, we had the pituitary gland. And in the pituitary gland, we have the hormone, antidiuretic hormone, sometimes also referred to as vasopressin. When we're talking about things like drugs to raise blood pressure, we have vasopressors, sometimes just referred to as pressors for things, and that's going to help to try and raise blood pressure. So if blood pressure is falling, oftentimes it's because blood volume is too low. And when blood volume is too low, we then get the release of ADH from the posterior pituitary. That posterior pituitary, remember, only stores the ADH. It doesn't actually produce it, so it's coming down from the hypothalamus, gets stored in the posterior pituitary, and then when it's needed, we're going to stimulate the release of that ADH. That ADH then goes all the way down to the kidneys, circulates through the whole body, but the only place where it's going to, in a sense, matter is in the kidneys at the distal convoluted tubule and the collecting tubules. And so in those areas, this is where now ADH is going to make some changes in the cells of the tubule. And so with that, what is going to occur is that it's going to stimulate those cells to produce aquaporins. And so if we remember back to the cell, we talked about aquaporins as being kind of these little proteins that allow for water to move through the cells themselves. And this is going to allow us to reabsorb more water. And so water reabsorption is increased, and that then allows us to get a larger amount of that fluid back from the urine. And so here we have ADH. ADH binds to its receptor, and that stimulates the cell, and more so in a sense the nucleus here, to start to stimulate the rest of the cell to make proteins. And these proteins are going to be our aquaporins. We now have more aquaporins than we had before. This is going to allow for the water to flow through the cells, so from the tubule in towards the capillary. And so it's going to allow for more and more reabsorption of water that way, and water is going to move back into the peritubular capillaries. So as we get more and more of those aquaporins, more ADH gets reabsorbed, and that's going to go along with it. If we were to block ADH, the production of those aquaporins is going to go down, and that's going to leave more water in the tubule. The more water in the tubule, the more dilute the urine is, the more urine production we get. And so in terms of inhibition of that ADH, one big thing that comes up often as far as the reduction of that production is alcohol. And so alcohol inhibits the release of antidiuretic hormone. And so even if we were already dehydrated ahead of time, that alcohol is going to inhibit that release of ADH. And so we don't get any ADH, which means that we get less and less of these aquaporins here, and more water is lost in the urine. So we're going to create that dilute urine in that particular scenario. And so that's why we need that ADH. Whenever we are dehydrated, it's going to allow us to increase that reabsorption of water. Another hormone that helps out in the formation of urine is when we have aldosterone. So once again, when blood pressure is low, and oftentimes this goes along with fluid volume being low, we're going to have the release of aldosterone. And so aldosterone is going to get released, and it's going to come down, and rather than necessarily just affecting the kidneys, it is going to alter its reabsorption, and it's also going to cause vasoconstriction. And so we're going to get the reabsorption of sodium to occur, and that's where sodium goes, water is going to follow. And so the two of them are going to go hand in hand on that. And then lastly, we have our renin. And so renin is released by the kidneys, and we'll see that it comes from that juxtaglomerular complex once again. And when the kidneys are monitoring that blood pressure, when blood pressure comes down, and so when we start to lose blood pressure inside the blood vessels, that renin then is going to help out in this particular case. So renin gets released. Renin is going to combine, and it's going to essentially serve as a catalyst to activate another protein that's floating around inside the blood. This protein is angiotensinogen. And so angiotensinogen is a protein. It's a hormone, much like all of our other hormones. And this inactive angiotensinogen then gets converted into angiotensin 1. And so angiotensin 1 is also inactive. And so we're not at the end of the process itself. In order to activate angiotensin 1, we need another enzyme. And so this next enzyme is going to be angiotensin converting enzyme, or ACE. And this ACE is going to convert our angiotensin 1 to angiotensin 2. Angiotensin 2 is now active. So this is now our active form of the hormone. And as it circulates around through the body, it's going to cause vasoconstriction. It's going to tell our brain that we're thirsty. So since our blood pressure has dropped, so BP is falling, this is possibly due to a volume that is falling. And in order to bring that back up, we're going to need to do things like drink. And so our thirst center is going to be stimulated. From there, we're also going to decrease the amount of water lost by the kidneys by inhibiting the water from being lost. And so we're going to increase the reabsorption of water. We're going to shut down the reabsorption of, or the loss of water by reabsorbing more of it. And that's going to allow us to start to bring back up our blood pressure as well. A little bit different picture, but basically kind of showing everything as well in kind of a diagram form here as well. So we start out with our angiotensinogen is circulating around in the bloodstream. From there, so that's being produced as one of our regular plasma proteins. So it's a protein that is circulating around in the bloodstream already. When we get the release of renin from the kidneys, that's then going to combine with our angiotensinogen to give us angiotensin 1. That's going to head over to the lungs, and the lungs are going to release angiotensin converting enzyme, or ACE, and that's going to get us our active angiotensin 2. This is then going to go back up to the posterior pituitary, so our posterior pituitary, and that's going to stimulate the release of antidiuretic hormone, or vasopressin. That increased vasopressin release leads to more water being reabsorbed, so we get more of those aquaporins being formed, and that's going to allow us to reabsorb more of that water. We're going to hit the thirst center. That's going to potentially make us drink more, so we're going to feel thirsty. We're going to have all those things that we normally experience in terms of thirst. And then one of the bigger things that it's going to do as well is vasoconstriction. All of that is going to lead to an increase in water in the body, and that's then going to reverse all of our initial symptoms in a sense. So whether it was extracellular fluid volume was low, whether it was our blood pressure that was low, whether it was our sodium levels that were low, whatever process it was that had altered our blood pressure to cause it to fall, or to cause our volume to fall, that's going to then be reversed. The last couple of things in the process here as well is we get the release of aldosterone from the adrenal glands, and then that's going to head over to the kidneys and cause for more sodium reabsorption. Where sodium reabsorption goes, water follows. And so we get that process where sodium as well as chloride ions are getting reabsorbed, and that's going to lead to more water being reabsorbed as well. And again, that further increases the amount of water that we now have in the system. Monitoring all of this and kind of looking at it once again is the juxtaglomerular complex. And so that juxtaglomerular complex has within it the juxtaglomerular cells. Those are going to be the source of our renin. And so renin is going to be released by them when the afferent blood flow is coming into the capillaries of our glomerulus there. Those juxtaglomerular cells are monitoring that pressure. And so if blood pressure has fallen as it's coming in, that's going to stimulate the release of renin, and that's going to get us our increase in angiotensinogen converting into angiotensin 1 to angiotensin 2, and then so on. And we're going to continue from that point on from there. As we're looking at the contents in the mesanglial cells here, we're going to be looking at what's actually coming in through the distal convoluted tubule, what's our sodium content, things like that, and we can start to alter our reabsorption at that point there as well. The kidneys are extremely important, and so they're our waste removal system. Think about it in terms of like if the garbage stopped getting picked up. And so if all of a sudden the garbage was not picked up this week for you, and then all of a sudden it wasn't picked up next week, and then the next week, and now a month has gone by and the garbage just isn't getting picked up. And what's going to start to happen? We're going to start to get the buildup of toxic wastes. So our garbage is going to start to smell, especially if this is like in the middle of summer and it's super hot, things like that. It's going to start to build some things. Bacteria is going to grow in it. Potentially viruses are going to grow in it. We're going to have other things coming along in terms of not really toxic waste, but we're setting ourselves up for disease in the body. Same thing goes with kind of pests that may be coming along. The mice, the rats, the raccoons, all of them are coming around and sniffing around looking for this waste that has been building up. And the same thing's happening inside our bodies. So the buildup of all of those toxic wastes, we're getting the buildup of urea, uric acid, creatinine, all building up in the body, all potentially leading to the damage occurring to other body systems. Our pH is going down, so our body is becoming acidic. So we now have a metabolic acidosis in this particular area of the body. That's going to lead to issues there. If we're not able to get rid of potassium, So if we weren't able to bring those potassium levels down on there, that's going to lead to potential issues there as well. Depending upon what's happening as far as our glomerular filtration rate, this is going to then also alter sodium levels. And depending upon if we have too much sodium, that's going to lead to an increase in blood pressure. Too little sodium and our blood pressure is going to start to fall. So it kind of depends there on whether the kidneys are losing or retaining that sodium at that point. Either way, our body is going to start to suffer. Those areas that rely upon sodium and chloride ions, our potassium ions, even our calcium ions, are all going to start to feel the effects in a sense because we're no longer balancing out those electrolytes. As within the body itself, we're going to potentially, especially if the glomeruli become kind of too leaky, this is going to lead to the loss of plasma proteins. And so if the glomerulus is allowing for larger substances to pass through, like plasma proteins, this is going to lead to problems elsewhere in the body as well. We may start to see edema build up because of that change in the protein balance that's normally there, where the plasma proteins are pulling fluid back into the bloodstream away from the tissues. If the kidneys are not working properly, then we're going to have a situation where we can't vary our urine concentration. So if the person is getting plenty of water, so if they're having lots of water intake, they're not going to be able to get rid of that water. And so they're going to have a decreased urine output, which then leads to, again, things like edema. And so we're going to have water going there. And the body, if we have edema, then is going to start to become hypotonic. And so we can have situations where we have a change there in the tonicity of the fluids surrounding all of our cells as well. As the kidney problems kind of continue on, as one of the things that the kidneys are doing is monitoring oxygen carrying capabilities in the blood, we have the potential loss or decrease in erythropoietin production. So we're going to have a decrease in red blood cells, which leads to a decrease in oxygen to the tissues. So our oxygen levels are going to fall down and eventually going to lead to the death of the person. And so without kidney function, or in terms of things that are there, you're going to have to, it's going to lead to the need for dialysis. And dialysis is then going to essentially take care of all of those things, except that it's not a long-term solution. And so the kidneys are required, and we need to be able to filter out the blood on a constant basis. And with that, we'll start to look into our electrolyte balance in the body as well.